So today the topic of our discussion is on the irritable bowel syndrome. Irritable bowel syndrome is also a very important topic. You'll often find patients suffering from irritable bowel syndrome. So what is irritable bowel syndrome? Irritable bowel syndrome, remember, this is a chronic symptom complex. Again, this is a chronic, okay, so this is a chronic symptom complex. And what happens in this irritable bowel syndrome? The patient mainly complains of altered bowel habits and abdominal pain. Remember, these are the two main things which occurs in irritable bowel syndrome. Patient complains of abdominal pain and altered bowel habits. But the thing in this irritable bowel syndrome is that you won't be able to find any organic cause. Okay, so no organic cause can be found. Okay, altered bowel habits. So irritable bowel syndrome, no organic cause can be found in irritable bowel syndrome. So why exactly, what is the reason, what is the etiology of this irritable bowel syndrome? In irritable bowel syndrome, there occurs altered GI motility. Okay, the motility of the GI tract, okay, the motility of the GI tract, that is altered. So what are the changes which occurs in the motility of the GI tract? That is, the patient will have altered gastric emptying. Okay, there'll be increased small bowel contractions, the contractions of the small intestine. Okay, so there'll be increased contractions of the small intestine. Okay, there'll be increased small intestinal transit. Okay, there'll be altered gastric emptying. So these are the main things which occurs in irritable bowel syndrome, right? So there occurs an altered GI motility. The motility of the GI tract is altered. The contractions of the small bowels are increased. Okay, the gastric emptying is altered. Okay, and what is like, although it's not certain, but maybe the neurotransmitters like serotonin, that play a very important role for this alteration of GI motility. Okay, so it is the serotonin which stimulates the intestinal secretion. It increases the small bowel contractions. Okay, it stimulates the peristalsis in the intestine. Clear? So this is one of the factors which can cause the irritable bowel syndrome. What else can cause? What else can be responsible for this irritable bowel syndrome? Certain psychological disturbances also. Remember, anxiety, tension. Okay. Then excessive, tension, excessive worry. Okay, so they all can also precipitate irritable bowel syndrome. Certain foods can also precipitate an attack. Okay, so these are the different, because in irritable bowel syndrome, I repeat once again, no organic cause can be found. Okay, so here the main changes which we see is the altered GI motility, the contractions and the transit time. Okay, transit. Okay, so in the small intestine, the transit in the small intestine, the contractions in the small intestine, they are increased, mainly because of this neurotransmitter serotonin, or excessive psychological disturbances like anxiety, stress, worry, that can also precipitate irritable bowel syndrome, or certain food can also precipitate irritable bowel syndrome. Now, clinical features, there are mainly three varieties of irritable bowel syndrome. These patients of irritable bowel syndrome, you will mainly come across three clinical variants. One group of patients will complain of diarrhea, another group of patients will complain of constipation, and another group of patients you'll find will complain of alternating diarrhea and constipation. Okay, so there are three clinical variants. The first one, those who are having spastic colitis. The first clinical variant, those who are having spastic colitis, and what do they complain of? They complain of chronic abdominal pain with they're going to complain of chronic abdominal pain with constipation. Clear? Another is the chronic intermittent watery diarrhea. In these patients of diarrhea, they usually, remember, the patients of constipation, they complain of this abdominal pain. Patients of this loose watery diarrhea, they often are without pain. Okay, so another group of patients are those with chronic intermittent watery diarrhea. This is the second variety of patient. Okay, and the third variety of patients, they are having alternating. Okay, so they are having features of alternating diarrhea and constipation. It's alternating diarrhea and constipation, that is called as mixed IBS. Okay, right? So they're having alternating constipation and diarrhea. And which is the most common group, age group which is affected? It is mainly the middle age group. There's 20 to 40 years. Okay, that is mainly affected here. And the females are mostly affected. Okay, and most of them, the most common presentation, most common symptom of this irritable bowel syndrome is abdominal pain. Okay, so this pain can either be present on the left side or the right iliac fossa or the hypogastrium. Okay, and what the patient will mainly complain of, the patient will say that after taking food, the pain is getting, provoked. The pain is often provoked by food. Okay, so food provokes pain and defecation. Okay, so that relieves the pain. Right? Food provokes pain, defecation relieves the pain. And in the diarrhea, the patients who are having diarrhea, they will complain of diarrhea mostly in the morning. Okay, these are some of the, some clinical features of irritable bowel syndrome. The patients will complain of diarrhea, painless diarrhea, which occurs in the morning. Okay, and in the constipation predominant variety, these patients will complain of stool, like hard stool, like pellet-like, pencil-like stool, pellet-like stool. Okay, and in these patients, those who are having diarrhea, mucus may or may not be present. Okay, mucus may or may not be present. So these are the main features that the patient is going to present to you with. Apart from this, the patient can also complain of abdominal distension, abdominal bloating. Okay, they are, they are having some food and they are not able to take much because they feel bloating, they feel abdominal extension. Okay, and during defecation, there is incomplete evacuation of the rectum. Okay, there is excessive flatus, dyspepsia, heartburn. Okay, so these are the other features also that the patient can present to you with. Okay, excessive flatus, excessive heartburn, dyspepsia. Okay, other features also the patient can present to you with. So if the patient comes and presents to you with these things, so what are the investigations which you are going to do? So again, the patient is complaining of diarrhea, chronic watery diarrhea. So you have to go for a stool examination. Okay, stool examination is required to rule out any infectious causes. Okay, and then we do the other tests like sigmoidoscopy, barium enema. Why do we do the sigmoidoscopy? To find out if any pathological, if there is any involvement of the mucosa, colonic mucosa. We get to see details of the colon, the lumen. Okay, so to rule out other causes. Okay, so first we go for the stool culture. Then we go for other investigations like sigmoidoscopy. In sigmoidoscopy, usually we see a normal vascular pattern, because in these patients, like in case of, as we saw in inflammatory bowel disease, there was inflammation, there were ulcers, but in these patients, they don't have any inflammation, they don't have any ulcers. Okay, in what you can actually see, what you might see in sigmoidoscopy is that the bowel that will have an increased motor activity, because just now we discussed, in these patients the small intestinal contractions are increased. Okay, the intestinal contractions, okay, so they are increased. The transit in the intestinal contractions, okay, the intestinal contractions, okay, so they are increased. So what you might see is that the motor activity in the bowel, that is increased, and there is spasm. Okay, so you can also see increased motor activity in the bowel, and you might have difficulty negotiating the rectosigmoid curve due to spasm in the bowel. Again, when you carry out barium enema, Again, you will find the mucosa is normal. Okay, so the mucosa is normal. There are no ulcerations, no polyps. Okay, so no other cause you can find. But what you can find is that you can find spasticity of the sigmoid colon. Okay, spasticity of the sigmoid colon, and because of so much spastic, increased motor activity, there there occurs a tubular appearance of the descending colon. Tubular appearance. Clear? So this is all about your investigations. Next, let us look at some diagnostic criteria. That is a Rome 4 criteria, the diagnostic criteria to accurately diagnose the irritable bowel disease. Okay, so Rome 4 criteria. So what does the Rome 4 criteria state? Rome 4 criteria states that if the patient is having recurrent abdominal pain, Rome 4 criteria. Rome 4 criteria, this is the diagnostic criteria for irritable bowel disease. Okay, so recurrent abdominal pain if the patient is having at least one day in a week for the past 3 weeks, which is associated, I'll talk about 3 symptoms here, if it is associated with at least 2 or more of the following. Okay, so what did I say you? The patient is having recurrent abdominal pain. Okay, recurrent abdominal pain for at least one day per week, and this is continuing for at least 3 months. Okay, plus if he is having at least 2 or more than 2 of these following 3 features, which I'm going to write down. That is, first is related to defecation. Okay, so there this abdominal pain, okay, so it may be increased or it may be unchanged by defecation. So overall it is related to defecation. Okay, the patient will say that this abdominal pain, either it is increased, decreased or unchanged by defecation. Okay, it is associated with a change in the stool frequency. Mainly here, in these patients, just remember to put it very simple language if I want to say you, these patients will mainly complain of abdominal pain and the altered bowel habits. They will complain of some problem in the stool. Okay, so like, the frequency has increased or the frequency has decreased, or the patient is having, watery diarrhea. There is a change in the stool form, the appearance. Either the patient is passing pellet-like stools, constipation dominant, or there is diarrhea. Something they will say related to the stool. Okay, they'll have altered bowel habits and they will have abdominal pain. Okay, so these 2 things you have to keep in your mind. Okay, so change in stool frequency, or there is change in the stool form or appearance. Okay, this abdominal pain is related to the stool. They will complain like this, that either after defecation the abdominal pain is decreasing, increasing, or it is unchanged. Okay, so this is one criteria. Okay, there's some other criteria also, but this is not not very much essential, but these criteria which I'm mentioning, they may support IBS, irritable bowel syndrome. That is, either they are having abnormal stool frequency, like more than 3 bowel movements per day, or less than 3 bowel movements per week. That will become 2 less, isn't it? Then abnormal stool form. Abnormal stool form, like either the stool is very hard or very loose or very watery. Okay. Abnormal stool form. Passage of mucus. Remember, these patients will never, these patients don't complain of passage of blood. If the patient is complaining of passage of blood, you have to think something else. Okay, in these patients, the patient often complain passage of mucus, not blood. And there is a bloating feeling or a feeling of abdominal distension, excessive flatus. Okay, and there is dyspepsia. These are some other supporting features. Clear? So this is about your Rome 4 criteria. Next is, what is your treatment? Okay, you diagnosed the patient of irritable bowel syndrome, you did sigmoidoscopy, you did barium enema, you didn't find anything, no ulcers, no inflammation, no polyps, okay, no other changes in the mucosa, okay, but you just found that there was a increased motor activity, there was spasms, and there was the main, these are the some features which you found, the spasticity, okay, of the sigmoid colon. Okay, so apart from that, you didn't find anything else. Then you came to the conclusion that the patient is suffering from irritable bowel syndrome. So what is the treatment? Okay, so treatment is very important, that it depends upon what type, whether it's a constipation predominant or whether it's a diarrhea predominant. So main important is the diet. The diet modification is very much required in these patients. We use the word low FODMAP diet. What is this low FODMAP diet? Low FODMAP, FODMAP, low FODMAP diet. FODMAP, F stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Okay, so you need to ask, the low FODMAP diet. This is quite helpful. Now, where will you find, this oligosaccharides and disaccharides, monosaccharides, polyols? Which things the patients should avoid? Remember, the low FODMAP diet, this FODMAPs, okay, they are mainly found in the lactose containing food. Okay, so you're going to ask the patient to avoid the lactose containing food. Okay, lactose containing food, artificial sweeteners. These are some of the things which you are going to advise the patient to avoid. What else? Legumes. So these FODMAPs, okay, so I give it to you, that is FODMAP, fermentable oligosaccharides, disaccharides, and monosaccharides, and polyols. Okay, so we mainly ask the patient to avoid these. Clear? Next, let us see what is the treatment. In case of constipation predominant IBS, what is the treatment we are going to give the patient? See, obviously, the first we'll start the patient by asking the patient to increase the fiber content, the roughage content of the diet, adding a bulk laxative. Okay, so first initial, we'll ask the patient to add a bulk laxative. Do you know any bulk laxative? Isabgol, psyllium. Okay, so these are the bulk laxatives which are available. Then we can ask the patient, we'll advise the patient, or we'll prescribe the patient certain prokinetic drugs. Okay, certain prokinetic drugs which will increase, because constipation, the patient is suffering from constipation. We will give him certain drugs which is going to increase the intestinal secretion of water and chloride. It will increase the intestinal secretion of water and chloride. So which drugs are these? These are mainly the tegaserod and frucalopride. Okay, tegaserod. Remember, these are used in the constipation dominant. Frucalopride. Okay, tegaserod, frucalopride. Okay, so and different, 5-HT4 agonist drugs, the prokinetic drugs. Okay, so what are these drugs going to do? They're going to increase the intestinal secretion of water and chloride. Clear? What else can you give the patient? You can also advise the patient, you can also prescribe the patient certain osmotic agents. Osmotic agents like polyethylene glycol, okay, lactulose. Lactulose syrups are available, isn't it? Milk of magnesia, lactulose, polyethylene glycol. Okay, so these are available. So you can ask the patient to these, if the simple, the bulk laxatives or the fiber, as I told you, increasing the fiber content, if those things fail, you can prescribe the patient these drugs. Okay, then again, there is another group of drugs which are called the secretagogues. That is, as I told you, it is going to increase the intestinal chloride secretion. That is your lubiprostone. You need to remember the name of these drugs. These are intestinal secretagogues, increasing the intestinal secretion of chloride. Okay, so like your lubiprostone, then you have got the linaclotide. These are the intestinal secretagogues. Clear? So how this lubiprostone is going to work? This lubiprostone mainly works on the chloride channels. Okay, it works on the chloride channels. It increases the water secretion in the feces so that the feces will become soft and the patient will be able to easily pass, okay, the feces. Similarly, the linaclotide, okay, so and there are other drugs also like plenacatide, okay, the other drugs also like plecanatide. So linaclotide, plecanatide, okay, so these are also going to activate the guanylate cyclase receptors, okay, and they are also going to cause the chloride channel activation. Okay, so they are all acting as secretagogues, increasing the secretion of chloride and water secretion into the intestine. They're helping in making the stool soft. Clear? Now, as I told you, these patients of constipation also complain of abdominal pain. Okay, to relieve abdominal pain, we often prescribe the anticholinergic drugs. Okay, anticholinergic agent, the most common anticholinergic agent which is prescribed for the relief of abdominal pain. Okay, that is your dicyclomine. Okay, dicyclomine is given to the patient. And apart from this, as I had told you, one of the main cause of irritable bowel syndrome is psychological disturbances. Okay, so therefore, we also give the patient some psychotropic drugs like amitriptyline. This also is very helpful. Okay, because as I just told you that one of the main causes of this irritable bowel syndrome is psychological stress. Okay, disturbances. So these are the treatment of the patient suffering from constipation dominant irritable bowel syndrome. We first start with just the bulk laxatives, okay, and increasing the roughage of fiber content of diet. Then we start giving them drugs which increases the water and chloride secretion in the intestine. We start giving them prokinetic drugs, prokinetic agents, okay, so which will increase the intestinal motility so that the patients will be relieved of constipation. We use drugs like tegacerod, cucalopride. We also prescribe the patients osmotic agents, okay, which will help in imbibing water in the stool and making the stool soft, like polyethylene glycol, lactulose. Okay, then we prescribe the patients some secretagogues, again, which is going to activate the chloride ion channels and it's going to increase the water and chloride secretion in the intestine, like lubiprostone, linaclotide, plecanatide. Okay. Next, come to the diarrhea predominant IBS. So both obviously the treatment of both of them are different. Okay, so diarrhea predominant IBS. Diarrhea predominant IBS, which is the drug which is prescribed here. We mainly prescribe the patient certain drugs like, there are a number of drugs. I'll just write down the drugs first and I'll explain to you one by one. First is the loperamide, very common drug which is given to the patients of diarrhea predominant. Then you have got the cholestyramine. Cholestyramine is a second line agent. It is not given initially. Okay. Then you have got drugs like, certain drugs, the 5-HT3 receptor antagonists, which is going to inhibit the excess amount of gastric motility. Like you have got drugs like ondansetron, granisetron. Okay. Then to relieve bloating and all, we advise the patients to take rifaximin. Okay. Then probiotics, they are also helpful in certain patients. Again, anticholinergics for pain control. Clear? And then we have got certain drugs like, okay, and then we have got certain drugs which is a mu receptor agonist. Okay, it decreases the bowel contractions. That is your, it is your just a minute. It's your eleusadoline. Okay, so let me discuss one by one. Yeah, so diarrhea predominant, first we prescribe the patient loperamide. This is given, can be given up to 4 times a day. It's most commonly prescribed drug. Then we can give drugs like cholestyramine. This is a bile acid sequestrant. Okay, it's a second line agent. This is because, why? What's the need of giving bile acid sequestrant? Because remember these bile acids, okay, so they also stimulate the colonic motility. They stimulate the motility, increase the motility of the colon. So by giving this bile acid sequestrants, this can also decrease the colonic motility. Okay, then we give this 5-HT3 antagonists. Okay, because this 5-HT3 receptor antagonists, the ondansetron, granisetron, they decrease the GI motility, because in these diarrhea predominant, we need to decrease the GI motility. Okay, then there is this drug rifaximin. Rifaximin may help to relieve this other symptoms, okay, like bloating, abdominal distension. Okay, so these are helped by this drug rifaximin. Then probiotics, you already know about them. Okay, so probiotics, they are helpful in these patients of diarrhea predominant IBS. They help in normalizing the gut microflora. Okay, then talking about the anticholinergics, again, they are helpful in those patients who are having pain, abdominal pain, along with diarrhea. Then you have got this drug eleuxadolin. Eleuxadolin, this is a the opioid, the opioid receptor, opioid receptor agonist. So what is this opioid going to do? This opioid is going to decrease the bowel contractions. Okay, it reduces the fluid secretions, it reduces the contraction, reduces the motility, reduces the secretions from the bowel. This is a opioid receptor agonist. Eleuxadolin. Yeah. So these are the treatment of the diarrhea predominant IBS. So this is all about the case of the irritable bowel syndrome. It's a very important topic because often you will face patients. Okay, so like the patients will mainly, these are female patients. They'll come and they'll complain to you with all such symptoms. They'll say, I'm having abdominal pain, having diarrhea, abdominal distension, dyspepsia, flatulence, number of symptoms. And when you carry out the investigations, okay, when you carry out all the tests, stool culture will come out negative. Okay, then when you do sigmoidoscopy, colonoscopy, barium minima, you won't find any findings. Okay, just you'll find that there is some spasticity, the motor movements, the motor activity of the bowel is increased. Then you come to a conclusion that the patient is suffering from irritable bowel disease or irritable bowel syndrome, and then accordingly you have to treat the patient. If the patient is suffering from constipation, you have to give him the drugs which I told you of constipation, the lubiprostone, tegasterod. As I told you, lubiprostone, that is commonly prescribed. Okay, so your tegasterod, prucalopride, osmotic agents. Obviously, first we start with giving the patient some bulk laxatives. If it doesn't work, then only we go to these other drugs like lactulose and as I told you, lubiprostone and polyethylene glycol, linaclotide. Okay, and diarrhea predominant, all these drugs are used. These are the second line drugs. Mainly we start with loperamide. We also give the patients rifaximin. Rifaximin is often also prescribed. Probiotics, anticholinergics, they are given if their patients are having abdominal pain. So this is the treatment of irritable bowel syndrome.